I shall introduce our speaker for today on his profile, and our guest, Dr. will start his sharing immediately after my introduction. Today, we are very privileged to have Dr. Norshaziman Sulaiman to share with us today. Dr. Norshaziman graduated from Royal College of Surgeons in Ireland and Penang Medical College with an MBBCH BAL in 2006. He obtained his Master in Radiology, MRAD, in 2013 from University Malaya, UM, and completed his fellowship in Interventional Radiology in 2016. He spent a year as a fellow in the National Cancer Center Hospital, Tokyo. Dr. Norshaziman has special interest in diagnostic and interventional radiology, specifically in abdominal cancer imaging and intervention, as well as vascular-related conditions. Dr. Norshaziman also actively involved in interventional oncology and cancer pain or palliative management. He is an active member of the multidisciplinary teams in University Malaya Medical Center, especially in cancer and hepatobiliary diseases. He has attended various interventional or imaging-related training, including peripheral vascular at National University Hospital, Singapore, arterial chemoembolization in Seoul National University Hospital, Korea, and interventional oncology and vascular training at Bangkok. He also actively contributes to teaching, research, and has published articles and presented in many forums in his area of expertise, both at national and international level. Without further delay, I would like to give a warm welcome to Dr. Norshaziman to start his sharing. Thank you, Doctor.
Thank you, Amy. You guys can hear me. Good afternoon, and very warm welcome to everyone who's willing to spend a Sunday with us in this short but sweet session. So my name is Dr. Norshaziman Sulaiman. People call me Dr. Shaz, and I'm here going to talk about my field of interest, which is what I'm doing now in Gleneagles Hospital, called Interventional Radiology. So a lot of you guys, when we talk about radiology in general, we think about X-rays, we think about MRIs, ultrasound, or CT scan. Now, interventional radiology is another extension of these things that you guys are used to. So let me just go ahead right here. So what is an interventional radiologist? We are actually a clinical doctor who performs image-guided procedures. Okay, we look at the image interpretation, and then we do treatments with the image as a guidance. Okay, so in all sense, we are a master of imaging, and we further use the imaging to treat patients. Okay, so it is actually a full clinical subspecialty, means like it is recognized as a specialty under radiology, and in overseas, there's actually a huge following with big groups internationally, with many conferences held annually. In Malaysia, we are at I would probably say infancy, or we are getting there. So a little bit of history about interventional radiology. So this guy called Dr. Dotter, who is actually what we call the father of intervention. So many of you guys, when you talk about angiogram, we think about cardiac, we think about the heart, we think about the angiogram of the heart for angioplasty. But actually, way before the cardiologists were to do these procedures, it was actually done by an interventional radiologist. So this Dr. Dotter accidentally used a catheter to open up a blood vessel on the leg of an elderly lady who ended up walking out of the hospital without having his or her leg removed. Okay, so as time progresses, in 1960s, there were more and more procedures introduced in the realm of interventional radiology. So how do we get there? So how do we get to become an interventional radiologist? So first and foremost, we have to be a graduate in radiology, which means we have to be a master's of medical imaging. And after spending 2 years as a full clinical radiologist, we start a 3-year fellowship program. Now, this program involves rotating in various hospitals in in Malaysia, as well as usually involves a stint about 1 year in overseas. So I gave to you this images, what we have on this right side. This is a typical operation suite where you see an interventional radiologist will do his or her work. And if you look at these images over here, these are actually the actual scenarios which you see in an interventional radiology suite. So it's similar to an operation theater, but with a lot more gadgets, right? So that's what it is. And interventional radiology actually has several, I would say multiple areas where people will have further specialization. Okay, I will group this first being the peripheral intervention, where you have anything below the neck. So when you talk about anything below the neck, we have the muscles and bones, the MSKs. Okay, we have the pain intervention. We have the vessels. Okay, from neck down, and we have interventional oncology. So these are interventionists who work both inside the blood vessel and also outside. And we are also involved heavily in the first line imaging, which means that if you don't know what's wrong with you, the first CT scan or MRI can also be looked at from an interventional radiologist. And from there on, we can pick up certain diseases that can be treated with image guidance. So we usually get ourselves heavily involved in multidisciplinary teams in big hospitals. Usually we get consulted on at the earliest stage on in terms of diagnosis and also whether there's anything that we can do to help. Okay, so I'm just going to go a bit about musculoskeletal and pain. Conditions that are treated by interventional radiologists would be things like a chronic back pain treatment, spine augmentation. For example, if you have a spinal fracture, an interventional radiologist can repair it. A herniated disc, okay, cancer-related pain, and also bone tumors. Now, for example, if you look at this, one might think, oh, actually, the spine doctors are also doing this. Yes, you are right. I would say that there is quite a few overlaps in what we as an interventional radiologist do, and also what some of the surgeons or some of the physicians are doing there. So I would say why is that so is because medicine is already a multidisciplinary area, and there's a lot of people who wants to enhance their skill would also do some other things such as what we see here. So let's look at the spine intervention. So this is a few images that I can show you, for example, of what people do to the spine. If you look at the left area here, this is actually a spine fracture. Okay, this usually happens in elderlies or in patients with brittle bones, and sometimes you get fractures causing back pain. And you can actually go in just without having to operate a patient, just using a X-ray guidance. You can go in and put in a needle and then strengthen the fracture bone with cement. So this can actually strengthen the bone and help with the pain that the patient is experiencing. Okay, another cause of back pain would probably be this, and as you can see, a needle is being placed along the bone, where sometimes the joints that are causing pain, and these are usually not really seen on X-rays, but it was be seen on other imaging like an MR or a CT scan, and these are the things that can be treated. I know back pain is one of the most annoying thing that we can have, and sometimes no matter what we do, it keeps on coming back to us. So there's a few things that we can do, ranging from physiotherapy all the way to interventional procedures, as you can see here. So this is spine intervention. So next we go to tumor. So I don't have an actual picture of a tumor right here, but for example, tumors of the bone. There's so many things we can do for tumors of the bone. And one thing that is the most commonly treated will be bone pain. As you can see, sometimes tumors can cause the bone to become very painful and it can fracture. So you can actually, an intervention radiologist can actually treat that pain by sort of burning the tumor. Okay, so we can burn the tumor without having to operate and open up the area where it's painful. So these are some of the things that can be done for pain and also for the musculoskeletal system. So next we go down to the endovascular work. So if you look at this, I'm talking right now about endovascular surgery. It is a term coined by the vascular surgeons. They call it endovascular surgery. And basically what it entails is treatment involving conditions of the blood vessels, which can be treated without having to go for operation. Okay, so things like an aneurysm, which is a big bubble in the blood vessel. Okay, motor vehicle accident causing the biggest blood vessel to tear. Okay, critical limb ischemia happens when someone has leg pain. So this is due to a lot of things, but sometimes when you have leg pain as you walk, you feel pain in your legs. It's usually something has to do with critical limb ischemia. Patient with diabetes sometimes have this problem as well. Vascular malformations are generally things that can be formed from a abnormal vessel joining together. Venous diseases. This you can see things like a varicose vein in the legs. When you look at down your calf and downwards, you can see some dilated veins that sometimes makes your leg feel very heavy and sometimes can make it also swell. Okay, and also things like angioplasties and stent grafts. So this is, for example, this happens with when you have dialysis, when you're on dialysis, and sometimes when you go to the dialysis center and they say, oh, you have some problem with your access. So we can actually, an intervention radiologist can actually open up the place where it's narrowed, where you usually have your dialysis access. We can open up with balloons and we can open up with stents. So it will further prolong the lifespan of your fistula site. So this is one of the common things that is being treated nowadays. And of course, vascular access. When we talk about vascular access, we talk about conditions where if you end up in the hospital and you end up in the hospital for a long time, and sometimes you want to avoid having to be punctured for the veins for giving medications or fluids. So for long stay patients, we can actually put in a single small tube into the blood vessel, which will last throughout your whole hospital stay and prevent the discomfort of having to multiple times puncturing your vessels. Okay, and also for chemotherapy patients. So we find that chemotherapy patients generally the blood vessels tend to become smaller and smaller as you progress and you take more and more chemotherapy. But putting a small pot, for example, a small access that we implant on the chest, we can actually provide you with a way for you to be given chemotherapy without destroying your other veins. So this is an example of an EVA. EVA is when you have this is actually in your abdomen and you have suddenly a big bulge here, which is like a balloon. So this is not supposed to be here. As you see here, it's supposed to be straight and you don't have this bubble. This bubble can be very dangerous and it can rupture and you can have serious bleeding inside your abdomen. So an interventional radiologist and a vascular surgeon can actually go up there and put things like this to close up the vessel and close this balloon, this bubble here. So this is endovascular graft. These are actually things that can be implanted in the body and can save you from an open surgery, because traditionally this kind of treatment, this kind of disease, you will actually have to cut open your stomach, your tummy in the abdomen, and it's a big surgery. Whereas if you do it under minimal invasive procedure like from the vascular surgeons or the interventionists, we go in from the small hole at the groin and put in everything through there, so we don't have to open up the patient. So if you can clearly see the benefit there. Things like Diva is another thing. It's also the biggest. This is actually a blood vessel that comes straight out from the heart. You usually see this condition, this bubble, after a motor vehicle accident, where you have an injury to the big blood vessel of your body. So this, if not treated, can be detrimental to your health and can be fatal. But just by putting a graft from inside and you open up like this, you can potentially avoid major surgery and treat the condition in one go. So yes, and this is an example of a vascular access. This is what I mean by putting in a port or a line for to enable patient to receive chemotherapy or receive any medication. So it can be implanted at the neck. Okay, this is actually on the chest wall. You don't really see this thing because it's usually put under the skin. So this is definitely a benefit for chemotherapy patients who wants to come in and out and take chemo regularly without having to damage the other vessels. Right. So that is peripheral intervention. Now we go to another exciting bit, which is the head, neck, and spine. So an interventional radiologist sometimes get called up for conditions in the brain and in the spine, and usually it entails any abnormality or any problems with the blood vessels of the brain. Okay, for example, sometimes you can have small aneurysms in the brain, and this usually comes after, usually the patient will come into the emergency with thunderclap or extremely excruciating headache. And when you do a CT or MRI, you can find that a bubble is there in the blood vessels. Usually you see this in relation to a hypertensive patient. So you can see that. So things that we can do will be to put in a few metal wires inside the bubble and close it off. Okay, so hence also avoiding major surgery, because imagine the other way to treat this condition is to actually have brain surgery. So with an interventional radiologist, what they can do is they can go in from a small nick in the groin and put in a coil from inside. Okay, stroke intervention is another thing. I think it's has picked up extraordinarily in Malaysia. As you all know, stroke is a condition that can literally cause a lot of problems if you come in late. Okay, so there is a term that we like to say, time is brain, which means that the faster you come into the hospital for any form of treatment due to stroke, the actually more brain tissue you can save. So, and stroke intervention done by interventional radiologists can usually remove big blood clots that get stuck in the brain for that gives you stroke. So um, there are successful stories involve a patient with a massive stroke coming into the hospital early, gets a treatment by removing the blood clot from the brain, and patient gets to walk out in a few days without any permanent symptoms. So I think this is something that needs to be further deliberated because stroke intervention is something that can literally save lives. And this is already a very big thing outside of Malaysia. And we are lucky in Malaysia, we do have the expertise and the ability to do the same thing. Okay, so brain and spine arterial venous malformations are generally abnormal blood vessels in the brain and also in the spine. Okay, for example, okay, let's go down again to stroke. It's, if you look at statistics, it shows that apart from heart disease, stroke is something that can cause a lot of problems. Okay, sometimes you might not pass away from stroke in the beginning, but you will be left disabled, you'll be left paralyzed, and you can't do anything. And it will certainly cause a lot of burden to yourself and for your caregivers. But again, if everything is treated early, if it's detected and the patient were to come in early, you can actually reverse all those things. Okay, and intervention radiologist plays a big role in management of acute big strokes in the brain. So I will show you some images. This is the example of a patient who came in into the emergency department with acute stroke. So if you look at this is the main blood vessel that supplies the brain, and it's supposed to be a lot more vessels that you can see. So there's something here blocking it. So it looks like that. Okay, there's something blocking it. So we go in, put in a small tube all the way to where the area of the blockage is, all the way up here. Use a vacuum pump to remove the clots, and after that you get to see a full picture of the vessel. So this is a success story that shows that early treatment of stroke can actually save a lot of lives, and also saves us gives us a benefit for everyone. Okay, as you can see there, from here it becomes to this. So that's clearly how we can play a role in management of acute stroke. Next, I would go to an area which I think is what I really have passion in, and that will be interventional oncology. So the we generally get ourselves involved in advanced cancer therapy in terms of diagnostic to find out what's wrong, and also for therapeutic means we also can treat cancer. So we complement an interventional oncologist, interventional radiologist complements modern cancer medicine. So if you look at the general perception when you talk about oncology, when you talk about cancer, the general public generally would go say oncology is treated by an oncologist. Actually, that is not true, because if you look at the recent presentation by the uh, Association of Cancer Research in America, if you look at cancer care, there are 5 pillars of cancer care. So if you look at the first, traditionally, when you have cancer, it is actually treated by the surgeons. Okay, ancient times and present is when you have something growing, you remove it. So that's surgery. Okay, and in the in the late 1800s, you have radiation therapy, which is radiotherapy, which used radiation to burn the tumor and reduce it or kill it. Okay, and then in the 1940s is when you start to have traditional chemotherapy that you come to know today. All right, so things like infusion of chemotherapy, you give all those things that you hear from seeing an oncologist. So this is traditional chemotherapy. Then next we go to 1998, where you have precision therapy. Now, precision therapy is very broad. It basically means something that is targeted to a particular area, and this is where an interventional radiologist generally have their role. So we already know where the cancer is because we use images to do diagnosis. So we can actually use that image that we have to further do things to treat cancers with much accuracy, right? And also precision therapy involves things like using the right drug for the right chemotherapy for the right cancer. So all cancers are not equal. All cancers are not twins. They are actually probably cousins. So they have different, not all tumors acts the same and reacts to a particular drug. So you have to actually tailor the traditional way. You have to tailor your medication to find the right one to treat your cancer. So this is when interventional oncologists play its role. And next, you will see immunotherapy. So now this is the next thing in oncology as well, and you actually use immune responses to target cancer cells and kill it off. So these 5 things makes up a very important pillar in cancer care. So it's no longer a single specialty treatment for cancer. Okay, so this is modern cancer care, right? So an interventional radiologist starts off with first doing a scan to diagnose if you have a tumor, and if you have a tumor, whether you have how extensive is your tumor. So an interventional radiologist can definitely read that because we are the masters of imaging. So the second thing that we can do is if you have a tumor, we can actually help the oncologist or help the attending doctor to take a sample of that particular area. So we use small needles like this, and we can take this is an example of the lung cancer. So we go in from a small needle into the lung, into the tumor, and take a sample of this. Now, one might say, why do we need to do this? Again, if you remember, we need samples of the tumor to, number one, confirm that this is a tumor. Number two, confirm the type of tumor so that we can actually give the patient the right kind of medication. So this is biopsies that can be done by an interventional radiologist. Next is things like ablation. Now, once you find a tumor, so sometimes the solution might not necessarily be surgery. There are certain conditions which a patient cannot go for surgery. Either the patient has a heart problem or too old to be treated with surgery, because surgery is an extensive treatment, extensive procedure. So we have things like ablation, which means that this is an example of a tumor in the cancer in the liver. So a small cancer can sometimes be treated by putting in a small needle like this, and then creating heat around here to burn. It's like a laser therapy, we call it. Okay, it's easier to understand. It's like a laser therapy where you put in a heat probe and you burn the area around here. So killing off the cancer or the tumor around this area. So you will see this in the earlier scan, and sometimes it can be treated with this ablation without having to go for open surgery. Okay, so it's something that can be done by an interventional radiologist. So we can burn tumors like this in the liver, lung, we can burn it in the kidney and the bone. So there's a lot of things where this probe, there's a lot of places where this probe can go. And things that we use will involve heat. We can use ice therapy as well. So there's so many things that can be offered. Now, chemoembolization is another thing where we, as an intervention radiologist, deliver chemotherapy precisely to where the tumor is. Okay, so the general terms of chemotherapy involves when you come in for chemotherapy, we will put in a line at the back of your hand or your forearm, and then we will give you medications. So generally, the medication will have to pass through the heart and then circulate around your body and eventually also reaching the cancer area. Now, while that is the general term which has been working so far, there are certain cancers which can be targeted more precisely. An example, as you can see here, is actually this is part of the liver, and there's a tumor inside the liver here. So this patient is not eligible probably for surgery or not eligible for ablation. So we can actually use a small wire which comes from the groin directly into where the tumor is, and then we can deliver chemotherapy directly into the cancer cells. So this is what I mean by precision medicine. We target exactly where it is, and we go right at the front door, and we can deliver a very little payload to the cancer. So this can generally this usually happens in the liver. Okay, so by doing this, you actually will preserve the rest of the liver tissue, and also you minimize any chemo that might spill out to the rest of the body. Right? So now that is chemo embolization. Now sometimes we have a problem, which means that the tumor is much larger. So what we can do is we can actually give internal radiation. So the same thing that we did before in the chemo, precision chemo, we can actually put the catheter, the wires into where exactly the liver. This is an example of the liver, and we will give radiation from inside. So now this form of radiation is called internal radiation. It's similar to radiotherapy, but if you look at radiotherapy, it usually involves shining a source from outside to inside, which means there will be other areas which you will have to radiate as well. For example, the skin or the abdomen, the stomach before it reaches the liver. In comparison, for selective internal radiation, we straight away go into the affected area and deploy the radiation inside, and it doesn't really burn elsewhere. Right. So Now, this is an image of a cancer of the bile duct, the biliary system, the bile duct, which means the drainage system of your liver. Okay, these are silent cancers. Generally, when it comes in, it will come in at a later stage where you have jaundice and you have pain. Okay, so some of the patients can get away with surgery, but a lot of the time, sometimes this might not be feasible. So we are at the stage where we want to help the patient to improve their quality of life, to let them not have any jaundice. And we can do this by, number one, an interventional radiologist can actually go in from the skin to drain out bile which is blocked and cannot go down because of the cancer. So which means that you will be jaundice free, you'll be pain free because there's already a tube removing bile that is in your liver that is being blocked by the cancer cells. Also, furthermore, we can actually put in a stent through the area where the cancer uh, closes off the hole, the area of the bile duct, and we can put in stents to open it up again so that at least bile can flow down and giving the patient a better quality of life. So like I said, one of the things that we can do is improving cancer patients' life. Quality of life is something very important, which we hold on to dearly, that we want the patient to be as comfortable as possible even when they are having terminal disease. Okay, and of course, chronic cancer pain, which means that sometimes patients with severe or extensive or advanced cancer lives out the rest of their lives with pain. So even with maximum painkillers, it's still there. So an interventional radiologist can sometimes alleviate or reduce the pain by doing procedures by removing or neutralizing the nerve receptors. So you can actually do that for certain diseases, okay? And this is actually quite important for someone who is in pain and in terminal disease because we don't want to be suffering for the rest of our lives, especially when we are in a terminal stage. So an interventional radiologist can help out in certain conditions. Okay, so this is oncology intervention. It is actually quite broad, and there are other things that can be done, but this is generally what is happening. So what's the value on intervention radiologists? Number one, I would say there's a few values according to who you are going to, yeah, who you are giving the value to. For for a patient, the value is an interventional radiologist can sometimes get you treated with in a more minimal invasive way, which means probably big surgery can be avoided. There probably be loss of less blood loss, and you probably don't have to stay in the hospital for long, okay, because you don't have a big area to heal. Okay, um, things like control pain management is something that can be offered. Okay, and also the ability to precisely target a disease or a tumor, okay, in terms of treatment is clearly has a lot of benefit. Okay, and in terms of an eye intervention radiologist, we can actually add on the value of a diagnostic imaging, which means your CT scan, MRI, which we can see and we can find. We can actually offer treatments that can be done on that particular condition. Now, I have to say that an interventional radiologist works with every specialty in the hospital. So we generally work on referrals and we generally work hand in hand with the primary doctors, let it be a surgeon or a doctor. So usually in a big hospital where we have a lot of experience and a lot of good, great consultants from the other specialty. So a lot of engagement is done with interventional radiology, and you will generally see this happening in big hospitals where you can have a lot of inputs from people giving you the best and optimum treatment. Okay, so in summary, interventional radiology is a recognized clinical field. We are actively involved in diagnosis and treatment of patients. We function just as any other specialist. I do report rounds, I have clinics, I follow up my patients as well, and we actually cover a broad range of medical areas. I might want to add, like, so you might wonder, why have you not heard of this before? Oh, I would say probably is due to the number of interventional radiologists in the country right now. As of this moment, at the back of my mind, I can only think that there is around maybe 40 or 50 of us scattered all over the peninsula, and maybe 3 or 4 in Sabah and Sarawak. So that's not many. Yeah, so that's probably why you don't really hear much about this, but we are around. Okay, so with that, I would like to thank you very much for listening. I will give it back to the host for further.
Thank you, Dr. Shasriman, for sharing today. You were right. Actually, for myself, I have not heard much about interventional radiologists, and today I'm very glad to find out more about interventional radiology from you. You mentioned that you are actually working closely together on all other specialty like surgeon and oncologist. So, but I see from your sharing that you also do interventional radiology. It's not called surgery. Is that called surgery when you did that for stroke and also oncology, like the laser, one of the laser treatment?
Okay, it is called, okay, the easier term will be called a surgery.
Yeah.
You can call it a surgery. So
Yes.
like I said, that's why an interventional radiologist operates just like any other doctors that you see.
But it's with minimal invasive, less blood loss. So what would be the situation where this interventional radiology surgery is not recommended?
Okay. Well, there will be a few instances where probably interventional radiology is not the best solution. Okay, that's why active engagement with the surgeons, for example, certain cancer at a certain place. Okay, science has shown that in this condition, surgery is the preferred choice, which gives you the most benefit. So those are the areas where recommendation goes first for the surgery, okay, and then after that it probably goes to the interventional radiologist. But again, there's few things that I would say that interventional radiology is not the best solution. Um, However, having said that, there are some areas where actually interventional radiology is the solution. For example, sometimes when you have a bleeding from the, let's say, the stomach, or bleeding from the colon, okay, which cannot be stopped by endoscopists, which means they do a scope, they find the bleeder, and sometimes it cannot be stopped. So the next possible option that usually is, it will probably be surgery and find the blood vessel and stop it. However, in a hospital with an interventional radiologist, after scope, they can send to an interventional radiologist to find the bleeder from the CT scan and from the angiogram, and actually put in some particles or some material to stop the bleeding from inside. Then you can avoid surgery altogether. Yeah, so it's a
Okay.
dynamic thing. It depends on separate each clinical situation.
Depends on situation. So I guess as I mentioned CT scan, you will be together with the machines that is scanning at the same time while you are doing the surgery.
Yes.
Okay. We have a question from our registration form. So to our guests who are attending today, if you have any question for Dr. Shazriman, feel free to post your question in the chat box. If you'd like to speak with Doctor, just let us know, and then our host will unmute you so you can speak with Doctor directly. Yeah, one question was asked is too much radiology is too much radiology harmful? I guess it's what he meant is probably is too much scanning or going for screening harmful.
Right. So yeah, I think that's one thing that a lot of people are wondering. Is too much radiation harmful? So the answer is yes and no. Okay. So what I mean by yes is too much unnecessary radiation is harmful to anyone. Okay. And we talk about especially younger kids, pregnant mothers. If possible, if there's a way for us to avoid giving radiation, that is probably the best route to take. However, okay, if the benefit of giving radiation in terms of X-ray or interventional radiology procedure outweighs the risk of if you do not go for it, then it is justifiable. So a radiologist, an intervention radiologist, works on a principle of ALARA. ALARA means as low as reasonably acceptable, which means that intervention radiologists usually really takes care of the amount of exposure that we give to a patient. If we can avoid it altogether, we will. And if we have to give, we will give them with the least amount as possible as we think is acceptable.
That's good to know. But just for someone who go on a maybe like a regular checkup on a yearly checkup, you know, some people they go for like mammogram, and they go for I know some people sometimes they go for lung X-ray because they're concerned, okay, with the health condition they have. Is there any timeline that you advise that is suitable, that you know don't go too often, like not do it more than once a year and things like that?
Okay, so it is interesting because actually the main X-rays are not the main source of radiation that you get every day. We are radiated every day from just sitting outside or going on an aeroplane. So the amount of radiation from a simple chest X-ray is so tiny that it's almost negligible. So I mean, if you're a pilot, you probably get more radiation than having an X-ray. So um, so I would say that for medical imaging, for diagnostic and screening centers, um, a little radiation is definitely can sometimes have more benefit, because especially when we're talking about cancers, early detection of cancer can literally uh, be a lifesaver. You find a small cancer anywhere, you can literally get cured from cancer if you find it early. So in terms of mammogram, you do a mammogram when you are required to, you can literally save your own life if you find a cancer early.
Completely agree with you, Doctor. We have a question in the chat box by one of our attendees today. What's the maximum duration the chemo pot can be left inside the body chest area? Is it more difficult to take it out the longer if it's left inside the body? Doctor, are you able to answer that?
Yes. Okay. So a chemo pot can last for quite some time. I mean, I've seen patients with chemo pot for over a year inside the body, and it's still usable. Okay. So it does not, okay, the level of difficulty probably increases a little bit if you leave it for quite some time, because the moment you put in a chemo pot, your body will start to wrap around it like a small to cover it, to make it more stable. Yeah. So but it is, there's no actual timeline for when, how long you can keep a pot. I've seen pots staying in a patient's body for some time, but the general recommendation is you will probably keep your pot for as long as the time you need to use the pot. Because once you've completed your cycle for chemotherapy, you've completed everything else, you don't have to have a pot anymore. You can remove it, and in the future, if you need it again, you can always put it back.
Okay, so her question is it more difficult to take it out if it's longer left inside the body? Does that make any changes if it's taken out earlier or later? Is it more difficult?
Okay, it'll be slightly more challenging to remove a pot that has been there for some time. It can be, but generally because of the location is just underneath the skin, it's usually not that difficult to remove. Yeah, and of course, if you just put it in, it's much easier to remove it if you do it in over 1 or 2 days lah.
Okay, our next question in the chat box is how about laser treatment in facial? Is it too much harmful? I think
Ah,
this case probably talk about laser treatment in facial, maybe about pigmentation removal.
okay. Fortunately, I won't be able to answer about laser treatment in facial. But I do not think that that entails using radiation, right? It's probably infrared or infrared laser would probably be a little bit different. So many apologies, I'm not able to actually answer that.
No worries, doctor. Our next question, fourth stage CA after surgery post-treatment by radiology and oral medication use have side effects better for the patient ongoing monitoring?
Okay, let me see. Fourth stage cancer after
Mhm.
surgery, post or issues. Uh, okay. Does it mean that you're talking about uh, how to monitor? Um, right. Um,
She's
okay.
saying that probably fourth stage
Uh-huh.
post-treatment and oral medication use, does it have any side effect for the
Oh,
patient? I think that's the
what
question.
side effects if you go for imaging, you mean, probably. Okay. As of now, that as far as I know, if you're on chemotherapy or if you've had radiotherapy, there is no contraindications for any imaging for to monitor yourself. So some patients from post surgery or post radiotherapy, they follow up using CT scan, some of them MRI, and some of them PET scans. But what medications they are using does not really uh, uh, um, does not really affect your monitoring.
Oh, I think what about the oral based on radiation oral chemo therapy for a patient
Mhm.
who takes the oral chemotherapy? Is there like a tremendous large amount of radiation that on the patient and also the people surrounding the patient who's taking this oral chemotherapy?
Okay, so oral chemotherapy generally do not have radiation, so it's practically fine. But probably this is actually the oncologist area. But from what I understand, usually there's definitely no radiation involved, unless you're talking about the radio embolization treatment, which I've mentioned in my lecture, where we give internal radiation. So now that is usually the type of radiation that we use is relatively safe after a certain period of time. So when we do that, we will generally explain to the patient what they can do and what they cannot do, and the radiation does not stay in the body for long, and the radiation distance is also very minimal. So what we use is generally something that radiates for only as far as about 1 centimeter from the source. So it's actually very shallow.
Yeah, 1 centimeter is actually very shallow. You're right. Next question that we have. Okay, does cryotherapy have radiation?
Right. So does cryotherapy have radiation? The answer is no. But if you do the cryotherapy using CT guidance or any image CT guidance, then you probably have some radiation from the CT. But the actual treatment itself, because the cryotherapy is basically using ice. So we create ice balls to kill a tumor. So that one doesn't really have radiation.
Next question we have, can IR, I think that's interventional radiology, be deployed to treat lower back problem involving the L4 and L5 disc impinging on the sciatic nerve causing pain from buttock to leg? If can, will it be too invasive?
Now, this question, it depends on the time. Like I said, if you have a problem with the disc, okay, if it's very recent, which is very acute, there is still a chance that you can actually suck out the disc area that is causing the blockage, okay, and but usually when you have back pain, it is something that has been troubling you for so long already. So by that point of time, maybe the treatment on the disc is not possible. However, it is possible to treat back pains by actually treating the nerve that is causing the pain. Okay, but this involves looking again at the MRI and discussing with the primary doctors, which usually will be the orthopedics or the rehab doctors. And if it can, will it be too invasive? Actually, no. Back pain treatments usually involve small needles, putting small needles at the back, and it's done on a daycare operation usually, and it's a very short procedure.
So what happened is that when a patient sees a specialist, like what you mentioned, orthopedic or probably heart-related, or maybe an oncologist, does the patient maybe like suggest to say that, oh, what about, interventional radiology? Is there any patient that would actually do that, come forward to the doctor and suggest perhaps some multi-surgery instead of invasive surgery?
Okay, it's an interesting question. I believe that with now in the age of information technology, a lot of patients have Google, a lot of patients have
Yes,
handphones,
that's
and we are seeing a lot more awareness in other methods of treatment. And it is interesting because okay, most patients tend to not ask, but we are seeing an increasing amount of patients who will say, doctor, can I have a second opinion, or is there any other way? Or if they know, if they already read about it, they will straight away ask doctor, can I have this done? Yeah.
You're right. With the information is so abundantly available on the internet, plus like Health Talk, I've also learned something new today. So definitely something to think of or to consider. Next question we have: Can radiology intervention help a patient who has many spots on both left and right of the liver, since surgery can't be done?
Okay. I'm assuming when you say spots, you are talking about the lot of things that can be spots in the liver. It can be something that is not dangerous. It can be tumor. Okay.
Yep, tumor. Yeah, she mentioned tumor.
So if it's tumor, she mentioned tumor, yeah. Okay. Right. Okay, if
She
it's
just added on
tumor,
tumor. Yeah.
okay. If it's tumor, okay, there is uh it, it, there is a chance that interventional radiology can help with controlling the disease. Okay. For example, usually if you have advanced liver cancer where the surgeons say, okay, we cannot operate on this, and then the oncologist say, okay, probably we have tried everything, it's still not working. So there is something called liver directed therapy, in which involves the intervention radiology, like the picture that I've shown earlier. We can actually go in and deliver chemotherapy or any other particles inside the liver while minimizing damage elsewhere. So the answer is probably yes, if that spots a tumor.
How about liver cyst? I think liver
Right.
cyst with IR surgery.
Okay, so interesting. Cysts are generally water bubbles. You can find cysts anywhere, and usually cysts does not cause problem unless it's big, right? So yes, if the answer is if a big cyst is causing problem, we can do something. An interventional radiologist can actually put in a small tube, remove the water, and actually use alcohol or ethanol to burn the walls of the tumor, so of the cyst, so that it doesn't expand again. So it's a procedure that can be done without having to operate.
Okay, That's fantastic news. All right, I guess that's a good answer to our guest who asked this question for today. Thank you so much, Doctor, for your time. And thank you to our guests for their questions, valuable questions and valuable answers. We have learned so much, I think, as a group or as myself, okay, that today has been such a interesting learning. I have just put up Dr. Norshaziman Sulaiman's information on screen that if you like to speak more and find out more about IR surgery or interventional radiology, you can make an appointment to see him. His consultation day and time at the bottom is Monday 1 to 5 and Friday 9 to 5. Thank you so much once again, Doctor, for spending a precious Sunday time with us. Thank you so much for your valuable sharing and also passing out this information that I'm sure our guests are very thankful and also very happy to know more about such a surgery available. Okay, so this is our feedback form. Please scan your feedback form on a QR code. Let us know your feedback for us to improve. Today is our 30th episode of the Pioneers Financial Services virtual health talk that we had since April 2020. It's almost 2 years now, coming up soon. And as the number COVID-19 number is actually increasing now, I guess a lot of people probably want to stay home. Okay, and this is the best time for you to learn and to find out more about health, because it's indeed health is our wealth. Okay, send us your positive comments that you have for Doctor, because we will send all your comments to Doctor after we have received all of them. Okay, so thank you so much to Gleneagles Hospital, Cape Kuala Lumpur, especially to Sarina and the marketing team for have always been bringing us fantastic, amazing doctors who have shared with us every month, okay, on valuable information. This is their Facebook, their Instagram, and also their LinkedIn. Follow them, add them, okay, because they also have many information that comes in on their site. All right, so the Pioneers Financial Services will represent Prudential. We are part of Prudential Assurance Malaysia Berhad and Pru Business Takaful. And a good news that has been announced this month is that Prudential has covered COVID-19 and all future pandemic in our medical health insurance, okay, from 22nd January for all new clients. This means that if clients, Prudential clients who wish to be admitted to hospital due to COVID-19 or future pandemic, which we don't know if they are in the future, okay, so you can experience an easy and seamless claim experience, okay, with a cashless facility. For all our Prudential clients, please reach out to your Prudential agent or a wealth advisor to find out more, all right, with no additional costs, okay. And our next health talk, all right, this is the QR code for you to sign up, to register to avoid disappointment. Tentatively, it's on the 6th of March. It's always on a Sunday, 3 o'clock for about an hour. At the moment, the topic and the speaker is to be confirmed. Okay, once we get a reply from Gleneagles marketing team, then we will inform our attendees that attend for today. All right. Okay, so this is me. My name is Amy. Get connected. This is my name card. All right, you can scan this QR code to get my number and also some of our social media website. Okay, so that we can stay connected. All right, and also the QR, the registration form to register for March will also be in this QR code. Okay, and this is the team. The team that our co-host that has been working together to bring this talk to you, that have been making sure that the registration form are received and then we send the emails out. Okay, thank you so much to the Pioneers Financial Services team members for the fantastic, good job. Okay, so we have a Facebook group that you can most welcome to follow us. All right, so we're expanding. If you know anyone who would like to join our team in providing financial advice to our clients, okay, who would like to change, please let us know anytime. And this is our last slide. Okay, we are also on YouTube, right? So all our talks that have been held since last year in the whole of 2021 has been uploaded to YouTube. So if you have missed out any of the talk, feel free to go to our YouTube channel to rewatch them. Okay, so later Dr. Shah's video will also be uploaded to the YouTube. Yes, thank you. Yes, this is our last slide for today, our feedback form and our next health talk. Thank you so much once again to everyone, especially to Dr. Shazriman for being with us here today. Wishing everyone a fantastic rest of a Sunday and an amazing week ahead for tomorrow. Thank you, everyone. Thank you. Bye.